So now we'll be moving to the panel discussion about mishaps in ART laboratory. The moderators of the panel discussion are our very own Dr. Swami sir. Along with him, we have Dr. Durai, a prominent leading embryologist with over 17 years of dedicated service at KIMS Fertility Center, Hyderabad. His journey in ART is underpinned by a robust academic foundation, holding a doctorate degree in cell biology from Annamalai University. He is the author of Quality Control in ART Laboratories, released by CRC Publications in the UK, showcasing his commitment to advancing the standards of practice in embryology. Beyond embryology, Dr. Durai has a keen interest in computational biology, particularly 2D image processing, highlighting his belief in integrating advanced technological approach to enhance ART methodologies. He is also a visiting consultant embryologist for West Africa. He always connects with fellow professionals, researchers for their skills enhancement. Thank you for being with us today, sir. I request the moderators to take over the session and introduce the panelists.
Good afternoon, everybody. Today, Durai is Rohit Sharma, I am Dravid, okay? So, we'll start the session. So, I would like to call my panelists, Dr. Sindhuja, Dr. Madan Kumar, Dr. Radhakrishnan, Ms. Priyanka Thomas, Mr. Gautam Suresh, Sudhagar Cholan, Amita Subramanian, and Sangeet Kumar. Please. It may happen anytime. It's not with junior, senior. And we can't predict and work. So the problem with embryology is that, we work with the raw material, which is biology. So predicting the outcome or the assumption is very, very difficult. So there are these slides what we made, Durai made around 10 questions, not questions, the events, which are all documented. It's not hypothecated. It is all documented, and it is very easy. Just you see the question and answer. If this happened to you or to a lab, what will happen? And it's not in any flow, because trouble won't come with announcement. So sometimes liquid nitrogen, sometimes CO2, sometimes temperature. So just it goes that and tell your experience. The ultimate is that if this situation happen, how to prevent. So always the wise will learn from the other's mistake. So that's what we want to tell you. It's a crisp one. Yeah. And meantime, I like to short introduction, self-introduction from everybody. Start with Sudhagar.
I'm Sudhakar Choran from Aishwarya Fertility Center.
I'm Sindhuja from Gleneagles Health City, Chennai.
I'm Radhakrishnan, Prashant Fertility Center, Chennai.
I'm Gautam from ARC Fertility Center.
Priyanka from the High Fertility Center.
Amita from Cloud9 Hospital.
Madan Kumar from Apollo Hospital.
Sangeet Kumar from Isha Fertility, Hyderabad.
So all these firms are embryologists, senior embryologists. So they have a huge experience. Just we want to have a small discussion. If this happen, what we'll do? Yeah, we'll start with the first one.
Good morning, everyone. Thanks, FOGCE, to organize such a good event. I think the second consecutive year they are doing. We are very happy to part of here. Thank you all the organizing team. So today, as Swami sir said, we are discussing not the hypothetical questions. These all well documented in the reputed laboratories around the world. We collected those data and want to, what in the situation if you are there. That what we are expecting from the panelists. And you can also share your views like the experts. So first, so everyone will start with the sperm. So first one, the couples will come, we'll start with the sperm. So what we can do, the semen analysis. In the semen analysis, in this scenario, one of the lab, they are counting, always giving the overestimated the motile sperms. He is doing count is correct, and the other morphology, everything is perfect with that with the embryologist, but only the rapid progression will be the higher side always. Then the supervisor is so curious how to know how this fellow only giving the rapid motility higher side. So panelists, if you are the supervisor, how you can identify the situation? Why he is giving more rapid other than that? Anyone can change you. It's not particular questions.
Okay. First, thank you for the opportunity. So, I think this error usually occurs because when a person is first starting in the lab, they always try to, when they see one field, they always count all the motile sperms. And then, because it is faster, it is moving, it is easier to count, and then they move to the next field. So, when we are training, we usually say your aim is to calculate 200 sperms. So, when you start, first count all the immotile sperms in the field, so that you don't overestimate the motile sperms in the field.
Thank you very much to give this opportunity. This question, the very junior level people, we are not supposed to give any...
So I hear sorry for the interruptions. For the S-ray latest information, most of the seniors is not capable as juniors semen in the term of semen analysis. That the data is showing. Seniors are poorer than the juniors. Seniors in the semen analysis I am telling. Because you are not doing very frequently, they are doing every day as a routine job, they are better than us.
They are not doing it at all.
Okay.
Most of us belittle andrology, but we have to understand that andrology is as important as embryology, and we ourselves should keep in touch that we should not forget our andrology skills. When we are training these people, if they are reporting repeated high motility, we should check if they have done enough validation of semen analysis before they can actually give the reports. So they say 50 samples is enough before is enough for validation, but more and more samples, our eyes has to actually get tuned to identifying what is rapid progression, what is non-progressive, and what is immotile. So they can just randomly, just looking at sample in 1 minute, they will tell us that this is this motility, but we should actually not do that. Take time to note the exact percentage and then do the calculation accordingly.
Yes, actually you have not completed a point.
Yes. At least we give a number of samples to that people to find it out what are all the moving sperms and what are all the non-moving sperms initially. Then we give in a macular chamber for the counting chamber can really helps to find it out that moving sperms especially.
In counting chamber there is a problem. If you delay for late, all sperms will aggregate in the center. The motility will increase. If example, if you put your drop and see, it will give some 40%. After 10 minutes you can see it will give 65%. All it will come around in the center to give the motility high.
Okay. As Amita ma'am said, validation is most important thing to the person to give the reports. And in this case, maybe the person who doing the motility assessment, if the person, the time of assessing the sperms, motile sperms also very important. If they're doing slowly means the one motile sperm will go into the another, the counting chamber means they will repeatedly counting the same motile sperms will happen.
Usually we do the counting motility with macular.
Macular chamber.
What's your opinion, ma'am? What's yours? No, what's your opinion asking in this question? What do you all, if you are a supervisor, what do you do?
Generally, we have a regular procedure where periodically each technician should be tested. There's something called glass beads or IQ beads. So that will be given to use the macular chamber, and this is done periodically. I think SAT sends, actually the samples also come from CDC there. So we have regular inspections, regular checkup. These results have to be sent. So that way we check uniformity here. So the same thing we can also repeat periodically, maybe every 6 months in a predetermined sample. You check the count and motility we know and give it to all the technicians, the same sample, and see what the result we get.
Yes, I agree with you. In India, it's the biggest challenge is we don't have any internal quality and external quality. If I want to check my capability, how do I check in India? Where do I check? There is any assessment?
No, every program, say for example A4, there is a chief embryologist. He should devise programs.
Who will check the chief embryologist?
Then there is not limited. Like you are asking who will.
No, I am now. If you are going to KIFA is there in Europe, like in US, some system is there. So why there is
No, these
where-
bodies we form, like AS and other bodies, they have to start. I've been telling her repeatedly from morning.
The external quality system should help us.
Yes, that kind of body should bring in accreditation. That's the only way you keep, checking this.
Okay, this here, the answer is the technician hounding the majority of the rapidly moving sperm twice. That's why he is able to give the motile sperms twice. The count also a bit twice, because that fellow is not faster as fast as a sperm. So here, as the students are there, now as Sujata madam said, everyone want to become an embryologist when to complete the course. It's not as it is. Because when you are the slowly embryology field is moving to the corporate world. So once you are entering to the job, you should need the proper training, validation and the real cases. So here the supervisor in the questions we hear is, he set some rules. So if you want to become an embryologist, the egg collection, the first stage is egg collection, you have to complete 15 numbers of the egg collection. So without missing anything, the trainee will do, then supervisor will check the same fluid. If you are not able to get any oocytes, so up to the 50, then he is allowed to do the individual egg collections. But here the problem is, on the 19th or 20th collection, he missed the oocytes. So the supervisor got the oocyte from when he rechecking. So, and at your stage, what you will do? How you can put the rule? This is the threshold for the trained embryologist on the egg collections. I hope I clear.
So I think the senior has made a good rule that they have to do at least 50 oocyte collections before doing it by themselves. I think before that they can even add that every time before the 50 oocyte collections by themselves, the senior would have screened the fluid and kept. That fluid can be rescreened by the junior for another 50 cases. That could be another criteria. But after that, missing one oocyte should not be a criteria for stopping it, because I'm sure the junior would have found a lot more oocytes after screening the fluid which the senior had left. So I think 50 is a good number, and the senior is supervising the one oocyte missing so that he doesn't miss it after the 50 cases. So I don't think that should be a cutoff for him to...
Here challenge is, after 20th collection, till 20th he didn't miss anything. After 20th collection he missed something. So
I think there are 30 more sessions, so he can evaluate based on that.
So continue from 21.
Yes,
that's
continue from 21.
Okay.
You can start from the first.
Okay.
Sorry,
okay.
Parada.
No, I want this the one, how we can evaluate.
We can start with the first.
Okay.
In our center, first embryologists do the screening.
Okay.
If the junior embryologists do, if they found one, they have to give 1,000 rupees for that.
Air level training.
அந்த ஃபர்ஸ்ட் 20 ஓசிஎஸ் அந்த சீனியர் செக் பண்ணதும் அவர் கரெக்டாக செக் பண்ணாரான்னு பார்க்கணும்ல சார்.
No, the senior, that will be the open lab. So you can't commit the assay, you are training, you can't suspect your supervisor, you never improvise. You should trust your, first of all the assay junior, you are a trainee, you should trust your senior, then only it will become.
We give an opportunity. Then up to the 50 oocytes retrieval.
So let's continue from 21st.
Yes, of course, continue.
Okay.
Madam, yeah, I think they have found it first 20 correct, so we can give the opportunity to continue.
From 21st, continue.
Enough, yeah.
Okay, madam.
You have to check if the technique of screening is correct, whether they are, going through the entire dish in a clockwise manner. Sometimes it gets stuck in the
he is doing Z.
But sometimes even seniors miss. So in our practice, if the number of eggs expected is say less than 5, another person definitely will check if there is some egg missed, because
rechecking.
So
rechecking is
irrespective of senior or junior.
You are giving the chance or not?
Yes.
21st, he can continue
we
from
can give.
Okay.
You can do continuous.
Can't depend on one
Continuous.
person all the time, right? So we have to
Yes.
have a backup.
No, what we are asking the question is, now the problem is in the 20th, number 20. As your supervisor, you can continue to 21st, or as sir said, you are from the beginning. That's my direct question.
We can continue, sir.
Continue.
He is not missing a form.
Sir?
So first of all, we should give a proper training to the junior. So once the training is given to him, he should not miss the oocyte. So we should give a very skill. He should have a lots of practice before he is touching the live sample.
Everyone telling seniors are missing the oocytes.
So it should be always the rechecking should be done always with the whatever the sample. Even senior check, it should be rechecked. So if the things are
keep on checking.
If we kept the thing like 50 or 30, whatever it is, he should achieve that. If he doesn't achieve that, then we should repeat from the first, what I feel.
Yeah, it's basically the experience what we are trying to give. See, for example, even in semen analysis, if one sample is given, if 50 of us do the semen analysis, there should be a gap between the difference between each one of us. There is a percentage, maybe 10% we can accept as per your lab. Then we are all same category. If someone is more gap, then we need more training. The basically we want to express is that they need more training. So you start from 1. It's very simple. See, even as a senior, I can miss 1 oocyte or 2 oocytes. So as Amita said, that is the right way. We have a set. We know KPI. We know that we will track the patient. Okay, this many oocytes. Even the clinician is having the KPI. I see he has to aspirate, and I have to identify that. And the gap should be minimum. And if any deviation is too much, then 2 people will check. It's very simple. Go to the next question.
That actually, she is maintaining a more lab.
Depends on the oocyte retrieval.
So, what's your opinion?
Retrieval also we can say. Fast retrieval.
Yes, see, that Sujata.
Clinicians fast retrieval.
So the thing is, here we have to see what kind of a sample, from what sample has that person has missed. Is it something which is very, with a lot of blood, with a lot of contamination, and in that, if that person has missed, then you can just continue from 21.
It's a normal one?
Yeah, but if it is just plain simple, this thing with very clear follicular fluid, and if the person has missed, then that shows some lack of concentration or lack of this thing, then maybe you don't have to start from first, you can start from little bit early.
Yeah.
So now we have collected the oocytes. Next is ICSI. Everyone is challenging here is the oocyte damage rate. So how the degeneration rate, how do you calculate? So here in the questions you are having is one fellow, so 5 embryos are working, only one fellow having the more degeneration rate than others, because when the KPI is in the place, we will come to know which fellow having the more degeneration rate. So what might be the reason? So the senior is doing one-on-one discussion, still he is not able to work it out, but after some reason he made some conclusion. So you are the supervisors, you are one of your team member having the more degeneration rate than the others, so what's your call?
Actually, it depends on the oocyte quality also. There may be damage.
No, here everything perfect, sir. Sperm perfect, oocyte perfect.
Technique of injection, plane of injection.
No, as a supervisor, what you will do directly?
I think we should have a stepwise discussion, starting right from the oocyte collection process itself. Since you said everything, oocyte quality, everything is same, then oocyte collection process, how long are they exposing it to the herpes media, how long are they storing it before keeping it in the incubator, then exposure to high lase time, that also has to be taken into consideration.
So
and of
stepwise
course, stepwise we have to discuss, and if anything can be rectified, it can be rectified.
Then, anyone? Why?
Yeah, the stepwise consideration should be very important. We have to check from the pickup egg collection to till ICSI, and while doing the ICSI, we should sit near to them and we should watch how they are doing, and we can take some points like how they are injecting, then alignment, everything, and we can give the suggestion to them to improve.
The challenge is here is everything is stepwise. That fellow also becomes, because once you are giving the independent ICSI, you might be the senior, you might do the better. But the problem is when your supervisor is there, anyone will not work independently, will be not comfortable.
Apprehension will be there, like no.
So in this case, that is another challenge.
If everything is fine, then it is question about the skill of that embryologist. So how he is performing the XC. So
maybe the technique. The technique will be
how he follows that we need to question.
So here in this case, after recording all the video, then analysis, one-to-one discussion, finally he concluded about he once injected, still he is on the place for more than 2 seconds, 3 seconds. He delayed to withdraw the needle. So it is giving the more resonator other compared to other procedures. So finally they rectify, then they rectify without the injection techniques. So here in this case, the injection techniques given the challenge to that degeneration rate.
So we have to understand the intrinsic inside the ICSI. It's not just going and coming inside. It's not only the technique, there is biology involved because we are dealing with the biological material. That is important. It looks one process, but in that we have lots of things. Even a 2 seconds can have a huge impact. That is what we want to emphasize.
Here the oocytes are fertilized. Okay. Now we injected, oocytes are fertilized, but the embryos are degenerated on day 3. So what we'll do? So patient has 3 routine ICSI procedures carried out in the frozen thawed semen testicular sperm. On each occasions, oocytes were fertilized, but all the embryos lysed within day 3. These all cases, initially we are telling this is not hypothetical questions. This already happened and well documented. It's not, we are just we try to put on 2 lines, but it's well documented.
It is fertilized but not turned up after day 3.
It's lysed within day 3.
So it's
any bacterial contamination?
Like a contamination.
Bacterial contamination.
Lysis.
Okay. Anything?
Poor culture condition.
That means?
Condition is not good.
All temperatures,
Yes,
suboptimal temperatures. Okay.
Sometimes power fluctuation happen and all those things.
Okay. But it is on occasion, every occasion, everything done. Fertilization happening, but the problem is within day 3 is degenerated.
Better do day 2 transfer.
Check for the media and whatever the expiry.
What are the possibilities this can happen? Like,
Anyone from the audience?
He is telling 3 times it has happened. It is not that it
Yeah.
has approved. Why you look at the media? Because all 3 times how the media can be wrong.
Yes, exactly.
Maybe the problem with
Samples, this has happened.
Yeah.
I think like that.
maybe the problem with the sample, sir, the testicular sample, maybe
Not with the oocyte. No, if you are doubting the sperm, then you should doubt the oocyte also. That's what I'm asking. And nothing wrong.
if we use the same sample for all the 3 times.
Yeah, same. Because it's a frozen third one. So anyone from the audience? Okay. So yeah, finally, so bacterial contamination. The bacteria called as the Morganella morgani. So name also difficult. This bacilli is because when he is not prepared properly. He not prepared the frozen sperm just directly, because why he is not prepared, that also the answer is there. He is scared because the motility is less. If I centrifuge, the motilities go down, I may not get the fertilization. That's why he didn't prepare. Whatever the motile sperm he injected along with the bacilli. That's a challenge. It is doing the job inside instead of the sperm. Then now embryo formed, fertilized. Now we come to the success rate. So a clinic was concerned about the low success rate. It is fertilized, clean, good blastocyst, and no implantation. Probably what it is. Why?
what are the possibilities?
Placement at the time of embryo transfer.
Okay. It's a new thing. So no, time.
Placement at
This may be, it's out of box.
So is this a question for
Placement embryo vela kekkuda.
Could be the lab air quality, because we have faced the same problem for one set of patient. We have got.
I appreciate, right? We have the problem. That word I am appreciate. Thank you.
So we have transferred for those patients. It almost like a few patients, like half of the patients, we got negative results. Then we checked, it was the problem with the filter. Then we have changed. Then we got good results. So could be the lab air quality.
I think lab parameters are also very important, and the same way as discussed. As discussed in the morning, immediate thawing, transferring immediately after thawing, giving some.
It's for VOC only. We only plays a role.
Air quality only.
Yeah.
And about the after the thawing, how many hours we giving also matters, sir.
So frozen embryo transfer.
So actually, the investigation revealed that more than 10 oocytes was transferred to the ICSI disk. It's a technique issue. Because that's what I'm telling interesting. We all suspect the air quality, culture condition, something, but the real is the technique how is performing. Embryologists spend at least 5 minutes carefully positioning each oocyte with the polar body exactly as that, like he is setting up the oocytes. The entire duration he took 10 oocytes, 6 minutes, 61 hour he spent to inject that. One dish is outside.
So you should inject, you should not love.
So because of that, the implantation rate was not right.
So basically we always suspect that I am right, I am perfect. Only external factors are influencing my result.
So then
it's not like that.
The recommendations was given only 2 oocytes per dish, then it will place on the results.
Swami, actually it's either this end of the spectrum or the other end of the
Yeah.
spectrum. Either you say somebody else is wrong,
Yeah.
or you even
Ourselves it's all.
My
How can you then consider the intermediate preparation, ET techniques?
This is one patient, I think.
No, here that's what in that study it's really clearly coding.
Because it's a blast
They
formation also
first
good.
clinically evaluated.
No.
It's
The
not
thing is
happening.
that these are all the real cases. We don't want to support the other documents. We took only for the embryology
Sir,
part.
at least 8 possible answers you should have, sir. Only one possible answer you have. Sir, உங்க ஆள் மனசுக்குள்ள போய் உங்களுக்கு எப்படி சார் தெரியும் என்ன நடந்துச்சு?
Now, I'll tell you where we got the reference also. You go and refer. In the IVF lab, life threatened to the embryologist. And you are safe at your lab? You all of you safe?
Oxygen depletion.
Yeah.
No, stressful though now.
Every time, because there is no airflow, because there is no air entered, because we are not having the...
You have AHU, right?
External, no, there is no AHU.
There's a liquid nitrogen smell.
Someone?
Because external air is not coming to the lab.
See, we don't want to restrict your imagination. That's why we are given open questions. Of course, that is called panel discussion. You send question one day, you prepare and come. Okay, I'm Swaminathan. We don't want. And what is the meaning of senior embryologist?
No,
it's not mandated that you have to answer the question. How you face the situation is panel discussion.
No, this is in 1995. 2 young researchers were found unconscious at the lab premises and died in the hospital after 1.5 hours in cardiopulmonary dissection.
So they are asking for lab குள்ள enter பண்ணும்போது எப்படி எல்லாம் சாகலாம்.
Not only lab, in office also. All the offices like that only now.
Then the pathology is dark red.
இல்லை, one more thing is that embryology labல சாவ மாட்டோங்கிறதும் நிச்சயம் கிடையாது. அங்கேயும் சாவலாம்.
Contamination ஆகாது சார்.
Sir, every day seeing the embryos, next day what is the condition of embryo? That is the threatening. Seeing the quality of embryo. Every day we are seeing what is the quality of embryo. So we are in...
Sir, அப்பப்ப டீ குடிக்க வந்தா அது இருக்காது சார். ஒரேடியா ஒர்க் பண்ண தான் சந்தர்ப்பம்.
Dark red coloration on the skin in the left arm was found on the researchers at autopsy.
So basically the liquid, we never take it very light. Liquid nitrogen handling. So until unless if I say that it is life threatening, at least you will give some point there. You at least next time when you see the liquid nitrogen, you will be little careful.
Not only the VOC is from the formaldehyde, SCHO is because it's all industries having the without formaldehyde we can't do any paper works or wood works, furnish works, all will contains SCHO. So it will emits that formaldehyde always.
A simple instance, maybe some 5-10 years back, I went to a lab, it's a new lab, they asked me to see, validate all that. I went inside the lab, I was getting nice diesel smell. I was wondering where no nearby, no petrol bunk or something. From where this is coming? Then slowly I went there. So what they did nicely, they kept the generator, the exhaust, very near to the inlet. So they are filtering the diesel, smoke. So these are all the small things, until unless the experience.
In this area, the nearby supermarket, the car parking is exit is.
Yeah, most of the time. These are all the things when you plan, as a team leader.
Not only that, sir. In some place, if it is near to hotel, we can get biryani smell also inside the lab.
Then you will go and eat.
I am considering only the egg, not the
If
Sudden
you eat,
maintenance activity.
Yeah.
So
Sudden
we have placed
maintenance.
that activated carbon in a pack of in the lab itself. So it's having the 1 gram of activated carbon. It will have the 27 square kilometer of UOC will be absorbed. So only so we can use it that pack. Every month you can activated charcoal.
Yeah, now it's a granules.
Because of in emergency also for toxics we in the emergency is using.
Basic absorption happens because of the surface area. Just to keep it in.
No, in the pack, full pack.
No, you have to kind of force your gas through it.
Yeah, pass through.
No, pass through also it will absorb. It's have the effect.
You mean to say that you keep it in one corner like
It's if you example if you have a cupric acid and you can put 2 tablets of activated carbon, it will absorb the cupric acids. Not only it not false.
then we can make a floor like that only, no? Yeah.
What we can do is in the inlet, wherever the inlet of the AHU, the fresh air where it's intake, that place should be, we should keep it very clean and neat. So it should be
Probably,
like, totally
Recently I had a problem, as I said. We are staying at 15th floor. My lab is in the 14th floor. It's a 16th floor building. The canteen is in the ground.
Smoke again.
There is a duct is there. My fellow is opening is there. That fellow kept the, I think one of our famous company will did. The inlet is open there. It is sucking the air from the ground floor to the 14th floor. Since we are new lab, we don't know where is the problem. Then one of the expert, he knows, so you change the intake, air intake. Then we open to the Hussain Sagar, now it is better. That the problem where it is, he is a ground floor, but still we are facing the problem.
Yeah. Yeah. I think this is the last question, no?
One more is that. This one.
Yeah.
So, I performed my first ICSI and found that no oocyte had been fertilized in the next day.
Most of the exes are like that only.
I troubleshoot the whole system and everything seemed to be fine. Where is the wrong? What is wrong gone wrong?
Simple say so many things.
temperature issue may be there.
Yeah.
Or I don't know whether they injected M2 or M1.
Those days.
Zona, we need to check about the NRO size as well.
No, we see when we talk about any technique, we will concentrate only on the major technique, major things. For example, when I say ICSI, oocyte, sperm, drop, PVP, injection, holding, swarming. There are other things. That's what we want to put small things. So see, when this happen, you can think it those lines also. It looks very simple, but this also will influence your result. That's what.
In what media they did the ICSI, whether in herpes buffer or fertilization medium, whether the time taken.
These are all the points you can add up.
Time taken for doing ICSI, how much?
Yeah.
For the culture after the ICSI and the incubator, we can check is there any problem with the incubator or other things, and we can check the egg quality and the sperm quality also if there any problem with that. And the person while doing the ICSI, he did it properly. The activation of the oocytes, everything done properly. We have to check all.
So these are all the major things. So this is small one, like the stage temperature. Even this could affect, like temperature, how important. We know that when we handle the oocytes outside or the embryos, the temperature is important. Even it may influence your ICSI procedure itself, that is also important. Yeah. Last.
So this question from morning we are discussing about the QC.
How long you can use the?
How long you can use the opened medium?
How long? As long as
Today
possible.
morning,
As long as
7 days we can keep it open. It's better to aliquate and keep, that can help us.
Can anyone tell what is this?
This is
This
PPT.
is the media precipitation. Is in the. So, as per recommendation, it's maximum 21 days they are telling. You can once open the media, it's a maximum of 21 days. Otherwise, you should not use the media. Otherwise, the precipitation once formed, the chemical structure will get collapse.
I think that's all.
This is the last one. That's it. So please take care of me. Think about the lunch? Okay. So, during the semen preparations, we are preparing the sample. Suddenly, the centrifuge stop working. This is something called as a PMS, Preventive Maintenance Schedule. How many of you are doing, we don't know. So, okay, in this situation, what we will do? We are preparing the semen sample. Suddenly, centrifuge stop working. How do you take up?
We will check for any sample remains with us.
Okay, but no bother about the inside sample?
So definitely, first we need a backup for that. So any frozen sample is with us or not, that we need to check for it.
Last question. This is the last question, so we'll go for lunch. Yes.
I think
We can try to maybe turn off the equipment and then try to open the lid if it is possible.
Okay.
We can check if the service person is nearby, if he can come and help us.
This is night 12 o'clock.
Like he said, if sample is remaining, we can do a direct swim up technique and give.
He's an actonal specialist.
VIP patient.
VIP patient. Yes, madam. Please.
If there's a remaining sample, like sir said, then direct swim up.
Okay, that is the option. What is the situation here we'll do?
So now YouTube videos are available. If anything goes wrong, how can...
But we should know how to. We should find out what the problem is, no sir. That is the first stage of troubleshooting.
That's why we are Google doctors. Anything?
So it's basically you should know to do basic things. What you have, even in untime, like 12 o'clock you are doing. So you should know basics about centrifuge, its principle. At least you should know where is the fuse. So, you know, there was an engineer who went to a lab. So the complaint was that there is no glow in the microscope. So he went and that thing, the switch was not on. So you should know, see, basically that's what troubleshooting, what it means, how you manage the situation. You can't wait, see, you are in a remote village, like you are in a 2-tier city, your engineers should come from Chennai. Even from Chennai, one place to one place, it will take 3 hours. So basic, like, you know, common sense, okay. Next, okay, what is the, that's why you have to read the manual, it's like Bible, it will tell, okay, how to do, what to do. So then if it is not possible, then we can. So you try to sort out as much as possible, like, you know, because it's called assisted reproductive technology. We deal with technology. Technology will come with too much of problem because we are depending on the machines, electricity, all these things. So one should be master in that also, at least to finish the job.
You know, every centrifuge has that. If you are using the F&F centrifuge, there is in the bottom one lever will be there. If you push it, the door will be open.
Same,
yes,
same, yeah, exactly.
Same techniques they have on all the centrifuge, but many of them.
Because the power is not there, you don't know how to open. Your lid won't come up. So thank you for your.
No, this is the book.
This is a nice book actually. You should
If you
go through.
are interested, go and check. There's more case studies are there. We collected from all over the world. But one sad thing in India, we never reported any negative things till now. Except India, Indian is all are going to happen good. We are very perfect. Thank you so much for your time during the lunch time. Thank you so much.
Thank you, moderators and
For
panelists.
your expertise. Thank you so much.
So we'll now have the felicitations.